Okay, good morning, everybody. I think we can start, and just a few things. If you need to exit, we are going to close this door and we leave open the rear door. So if you need to come back, you should use the rear door, okay? So we are not going to be disturbed by the people that are coming during the presentations. Okay, so thank you very much for being here. This is our second edition of the Milan workshop of computational methods for mental health and well-being. The workshop is organized by the Multimedia Signal Processing Laboratory Group, which is the group that I lead. And this is one of the activities of another group, which is the Mindful Group. The Mindful Group is an unstructured and not formal group that started the activities last year after the first edition of this workshop, because the common interest was very high, and so we decided to join in order to try to do several stuff like organizing workshop, organizing a special session within conferences, apply for projects maybe in the future. So this is just an informal group, but maybe we will grow and we will do very nice stuff in the future. So the interest towards these topics is very high, and you can see we have several supporters because, of course, we belong to the Department of Computer Science of the University of Milan Bicocca, so the first supporter is our department, and in particular the project of excellence that we won 2 years ago, I think, which is called Regains. But we have also other supporters. The order is not relative to the importance of the supporter, but it's just what I remember. The order is what I have in my mind. So one of the supporters is the NeuroMe Center, which is the Milan Center for Neuroscience, which is another Milan group that works on topics related to neuroscience. We have also the AGIT project, which is a PNRR project related to elderly. And then we have also the IEEE Italian section that supported us, as well as other two projects, actually one project which is DIPS, that is Digital Intervention in Psychiatric and Psychological Services, and the startup of our colleague that is Watadata. So thank you very much to all our supporters that allows us to... Ah, yes, he told me that I didn't remember to present myself. Sorry for that. I am Francesca Gasparini. I am at the Department of Computer Science here in Milano Bicocca. And yes, I am going to introduce all the other colleagues that are working with us. So this was the first edition exactly 1 year ago. That was really a successful event, and this is why we decided to do the second edition. And as I told you, this is one of the activities that are related to this group, the Mindful Group. We also have organized a special session during a conference that will be in September at the Polytechnic of Milan. Here you can find the references. We have three of us as chairs of this, of the Mindful Group, as chairs of this session, but actually all of us worked for this special session, and we are very proud because for the first edition we had 9 submissions, so it was a great success. And I invite you all, if you can, of course, to attend this event in September. And the Mindful Group actually is composed of researchers from 3 institutions, mainly the University of Milano Bicocca, of course, the Polytechnic of Milan, and the University of Milano Statale. And we cover several disciplines, from medicine to statistics to computer science, engineering, and so on, and psychology, of course, sorry. So it's very interesting because we put together different competencies, and we think that this is the great strength of our group. So now, coming to the event, the today event, we will start in few minutes, and the event is actually organized into 4 sessions. Thematic sessions. So the first one is related to computational neuroscience. Then we have the LLM in mental disorder session. And after the lunch, we have processing for digital health records. And finally, again, LLM in mental disorders. And 2 sessions about the same topic, which is one of the probably most famous in this moment topic. So during the whole day, we will have 2 coffee breaks, one in the morning and one in the afternoon. And we are happy to offer you the coffee breaks, while unfortunately during the lunchtime we can't we can't do the same. So the lunch is free, and each of us can organize as well as he or she prefer. So what we decided to do is to have the presentation, and then after the first group of presentation, we will have 15 minutes of discussion in order to proceed quickly, because we have several contributions, and we would like to give enough time to all of you that are going to present their work. So at the end, we will also have a round table to discuss about the topics that we faced during the day. So another information is that the meeting is going to be is recorded and is going to be available on YouTube. Actually, is on YouTube right now. This is the QR code if you want to access to the YouTube streaming. And yes, I think we can start. I hope you will enjoy the day, and thank you very much again for being here. I think I stay here because I am also the chair of the first session, which is the Computational Neuroscience session. So I would like to invite Stefania Coelli to, hi Stefania, to present her work. Stefania is an assistant professor at Politecnico di Milano, working in the Biosignal, Bioimaging and Bioinformatics Laboratory. And the title of the contribution is From Static to Dynamic Functional Connectivity to Study Brain Networks, Underlying Cognition and Motor Control. So thank you very much. I leave you the floor.
So good morning, and thank you for the introduction. So today I'd like to present some approaches to study both static and dynamic functional connectivity to analyze brain networks, in particular for cognition and motor control. So we know that the human brain is a complex system, and its function is given by a good balance between both anatomical and functional segregation and integration. This means that while we need an efficient communication among regions of the brain that are distant, we also know that specific functions are supported by a subset of regions that work in network in a segregated way. So this is actually true at different spatial scales, so from the micro scale to the macro scale, but we can also call it the global or the whole level network, brain network. That is what I'm going to show you today. So brain network can be defined as the interconnected system of brain regions and the pathway that connect them. In particular, brain regions and pathways can be represented as nodes and edges respectively, and together they form what can be called a graph. So how we can define nodes in a brain network? It depends on the analysis method we are using. For example, we can select or attribute nodes to a sensor of the device we are using to record the brain activity, such as the EEG. Or we can move to the to the source level, and in that case, nodes are the sources within the cortical layers. Otherwise, we can use anatomical region of interest. As for the edges, these can be represented as some sort of statistical relationship among the activity of each node. And there are actually several families of methods to estimate this connection, and the main two are the functional undirected connectivity and the functional directed connectivity that can be also called effective. In this case, we also have the information related to the direction of the connection. So there are several steps that we need to compute to arrive at the graph analysis. So first of all, we need to define the nodes, of course. For example, I will show you some work in which we define the node as the channel of the EEG, so in the sensor level. We need to select the data frame, so the time interval of activity we want to study, and if from this interval we extract only one network at the end, this is what we can call the static framework. So we of course need to select the connectivity index that gives us a representation that is called the connectivity matrix, where each element is the connectivity between two nodes, for example, and then we may apply a thresholding approach to only keep the statistically significant connection, and then we have our graph that can be analyzed using topological parameters that are part of the graph analysis approach, and these help us to summarize the characteristic of the brain network. So using the static approach, we did several projects through the year. And in particular, in this case, for example, we wanted to investigate the visuomotor integration network using EEG-based effective connectivity. To do this, we collected EEG recordings on 44 healthy participants while they were asked to perform a manual dexterity motor task, that was the 9-hole peg test with both the hands. And then we analyzed 20 seconds of activity at rest and 20 seconds during both the motor task. To extract functional connectivity, we use the phase slope index, that is a directed method, even if it is pairwise. And this can be computed in different frequency bands. For example, we analyze the theta and the sensory motor reforms, that are the mu and the beta band. So that when applying a threshold, we obtain a binarized connectivity matrix, and so a binarized graph, from which we extracted some parameters, in particular the degree, that is a measure of how connected is the network, global efficiency, that is a measure of integration, and modularity, that instead measure the segregation of the network. As a result, first of all, in terms of activation, we observed an increase in synchronization for the theta frequency band in both the right and the left hand movement with respect to baseline, and then a desynchronization that was actually expected at the central level in the sensory motor reform. For what concerns the network, we observed an increase in connectivity for the theta and a decrease for both the sensory motor network, even if it is more evident for the mu activity. And this is actually expected, And it was also supported by the graph parameters, since we had a significant decrease in the degree and a decrease also in global efficiency for the mu frequency band and increase in modularity. These we can say support the idea that during a motor task there is a reconfiguration of network, and this may depend on the frequency we are observing. And then the same approach, analysis approach, was also employed for this project that was carried out by Alessandra Calcagno, that is now a postdoc in the University of Milano. And the aim of this work was to investigate brain activity that support realistic programming. So I'm not, sorry, a fly. So I'm not going in detail about the protocol, but we use the same phase loop index to analyze the activity of the brain while the subjects were programming or doing some kind of cognitive exercises. And in particular, we observe an increase in connectivity for the theta band. That is actually interesting because the theta band is supporting cognitive processing. And in particular during P1, P2 and P3, that are the three phases of programming, this connectivity was increased from the parietal region, where there is the initial processing of inputs, to the frontal region, where we have high-level reasoning. So both these two projects were carried out using the static approach, but we know that the brain interaction are not static, and that's why we introduced a concept that is the dynamic functional connectivity, that according to Battaglia and Brovelli is the temporal variability of functional connectivity in brain networks. So the static framework should be improved, and we need to introduce the time dimension. And to do this, we can have several approaches. The first, that is the most famous one, is the sliding windows. This can be applied to continuous data or to data that are organized in several repetitions, so trials. And it is very simple. Basically, we need just to identify the time resolution we want to consider. We set the width of a window, and we move the window across our data, and we obtain the connectivity matrix for each window. And then we end up with a three-dimensional connectivity matrix, where the third dimension is time, of course. Otherwise, we can use instantaneous method, so method that allow us to have a connectivity representation sample by sample. This can be done by exploiting the trial dimension. So, for example, using phase-based approaches, we can extract instantaneous phase using different methods such as wavelet or the Hilbert transform, and then for each pair of node we can compute the difference of the instantaneous phase, and to have a robust estimation we average usually across trial, so that then we can compute different kind of connectivity indexes. Otherwise, we can use time variant models. In this case, we have a computationally demanding approach, but it is multivariate and provide us a method to extract a directed connectivity index. And then also in this case we have sample by sample the extraction of a model, and to do this we need an adaptation approach that can be done using the Kalman filters, but we need to set two parameters. One is the model order and the other one is the adaptation coefficient, so it is a little bit more complex. In particular, using this last approach, Martina, that is here, she's a PhD student in our lab. She's moving from the static to the dynamic approach for this kind of project, let's say. So the aim of this first project was to investigate the performance of modeling, time variant modeling, and the effect of different values of the parameters using a realistic simulation study, and then use this approach to study dynamical functional connectivity patterns for real data, in particular in a task where the subjects were asked to point to a target after a cue was presented. So we decided to use only 6 nodes in this case, because modeling is more node we have, more complex is the model. So we first did a simulation in which the simulated data were very similar to the EEG we had. So the same sampling frequency, number of channel, and length of the trial. We applied the connectivity index, that is the adaptive partial directed coherence, and as performance measure we used the mean spectral error, the mean squared error. And basically this was used to understand if the pattern of connectivity that was changed from it was at the start between node 1 to 3 and then to node 1 to 2 was detected by the method. So these are the results, and in particular for the multi-trial Kalman filter, we can see that changing the adaptation coefficient, we have different results. If the coefficient is very high, this means that the model is very fast, but it's also unstable, while using lower C, we have a better result. In particular, we also compare this on the right with the single trial Kalman filter, and we obtain actually also a good result with low error and the correct detection. So we apply this to the real data, and what we can observe if we look at the outflow for each node is that in particular after the target, so during the movement, we have an increase in the outflow for the C3, that is on the contralateral motor cortex with respect to the movement, and this is theoretically correct. And in particular we also have that C3 act as the main source in the network, while the parietal region is acting as a receiver. And this is also interesting because in the parietal region we have the sensory motor feedback, so it is we can be satisfied by these results. Another approach that we are also trying is the sliding window approach. This is also part of Martina PhD project and is still ongoing, so I will show you only preliminary results. Basically, in this case, if we use the sliding window, we end up with this three-dimensional matrix that is different, that is difficult to analyze. So we need to find a way to infer the dynamic information. One approach may be to extract the parameters for each window and then observe its dynamic. Otherwise, we can insert the time within the computation of this kind of matrix. So for example, we have the multi-layer community structure that take in consideration also time. This approach was applied to for tracking brain network during an action observation task. The action observation task was basically we asked two subjects to look at a video clip where a movement was performed, and in a preliminary study we observed that actually this kind of task activate the same areas that are active also during a motor task. So we applied the sliding window approach to understand if also the network changes during the observation, and we apply in this case a phase-based connectivity index that was averaged across the 20 repetition of the task. So as for classical graph analysis, we observe that during the observation we have a decrease in global efficiency and also of connectivity, and this support our hypothesis that we have a reconfiguration in the network. And so we decided to go on with the computation of the multi-layer modularity approach that basically give us this kind of representation where we have for each time window the association of the node to a specific module. And this should be done several times because it is an heuristic approach, and then it is compared to a randomized model to observe, to understand if the structure we are extracting is significant. This is what we obtain on all our subjects, and what we can see is that for most of them, after the second red line, that is the start of the video clip, we have a reconfiguration in the network. So now we are trying to summarize these results. A way is to apply, for example, the consensus matrix across all subjects in two regions, time regions, and what we obtain is, at least for now, is this representation where we can see that the structure, the common structure among all the subjects before the video start and during the video is different. So we, let's say, these results are interesting for us and promising. So to conclude, let's say that from this presentation, what I want to say is that thanks to the high time resolution neuroimaging technique that we have now, we can track networks and their organization over time. Of course, this is a new and open field of research, so there are several challenges that are still to be addressed, but I think that is worth continue to investigate in this field. So this is my presentation. Thank you for the attention, and I want to thank all the participants in the project, and Martina and the Professor Bianchi that are here today. Okay.
Thank you very much. We will do the question later, so we can continue with the next speaker, which is Letizia Squarcina. She is a researcher at the Department of Pathophysiology, thank you, sorry, and Transportation at the University of Milan. Her contribution is magnetic resonance imaging methodologies in major psychiatric disorders. I leave you the floor, Letizia. Thank you.
Okay, so thank you for the opportunity of being here. I really appreciate it. In this brief talk, I will show you a couple of magnetic resonance techniques applied in psychiatry, in particular in major psychiatric disorders. First of all, I will introduce the concept of the use of MRI in psychiatry. Then we will see which techniques we mostly use for acquisition, for the study of mental health. Then I will show you a couple of practical examples, a couple of applications to the dataset we acquired in our department. Okay. So, first of all, in the last decades, magnetic resonance imaging has been, MRI from now on, has been used extensively to study the neurobiology of psychiatric disorders in the effort of finding the biological causes of or correlates of psychiatric disorders. And there are several key brain areas related to cognition or to emotions, especially, such as the prefrontal cortex, the hippocampus, the amygdala, the limbic system, and the insula, which consistently show up in the result of the study, indicating that these key areas are involved in the pathophysiology of the major psychiatric disorders. So in particular, which are the sequences we use to see what happens in the brain of patients? First of all, one of the most used is the structural MRI. It's a T1 weighted imaging in which we see very well the contrast between white matter, gray matter, and CSF. With these kind of sequences, we can measure the brain volumes, the cortical volumes, the white matter volumes, and also the cortical thickness and the shape of the cortex. In studies using these sequences, we can mostly find reduced cortical thickness, which indicates that the patients go towards something we can see it similar to atrophy, especially in prefrontal and temporal cortex. And we see this in all major psychiatric disorders, especially depression, bipolar disorder, and schizophrenia. Another widely used technique is diffusion tensor imaging, DTI, with which, thanks to some gradients, magnetic gradients, which are sensitive to water diffusion, we can assess the integrity of white matter, in particular the integrity of white matter tracts connecting the different brain areas. And the mostly widely used index is fractional anisotropy, which is related to the integrity of white matter, in particular related to myelin and axons. And we see that in bipolar disorder and schizophrenia, but also in other mental health conditions as depression or even autism and neurodevelopmental disorders, the FA decreases, mirroring a loss of white matter integrity, especially in frontolimbic tracts, regarding mood disorders, which are tracts related to emotional dysregulation. The same tracts the same areas results to be disrupted if we analyze data acquired with functional MRI. Functional MRI is related to brain activity, and we can see when the brain activates in relation to tasks, cognitive tasks, motor tasks, or even at rest. And we found also here that in mood disorder, the frontolimbic connectivity is disrupted. Another maybe less used technique, but not less important, is magnetic resonance spectroscopy. These techniques gives us signals and not images. And with these signals, we can quantify in vivo the neurochemical metabolites in specific areas of the brain. So it's related to the metabolism of the brain. And with this, we still see changes, in particular in the prefrontal and cingulate cortex, in all mood disorders. So, having seen which are the most widely used magnetic resonance acquisition technique, I wanted to show you just a couple of examples of some novel techniques applied to this kind of data. So, first of all, a couple of applications of machine learning. In this work, we published in Neuroimage some time ago. We tried to define a machine learning method which could deal with some problems we face very often in medical clinical data sets. In this case in particular, we had participants coming from two different MRI acquisition systems, one at 1.5 Tesla and one at 3 Tesla. This is a common problem found on clinical data sets, especially in data sets coming from multicentric studies. In this case, we had 65 patients, first episode psychosis patients, and 65 controls coming from acquisition at 1.5 Tesla, and 62 patients and 62 controls coming from a machine at 3 Tesla. We also took into account covariates, which usually add some noise to the data. In particular, in the next analysis, we took into account the age of the patients. And we wanted to develop and test a machine learning model which could be capable of finding biomarkers for first episode psychosis. First episode psychosis is interesting because patients are have just a small amount of years, and they are usually not medicated or medicated just for a small period. So our hypothesis was that the covariates, so in our case, the covariates were the machine they are coming from and the age. Our hypothesis was that the covariates are somehow disrupting the machine learning process. So we hypothesized that adding the covariates in the learning process could help us to distinguish the class the patients were coming from. In particular, this was a multiple kernel learning method, so we had a kernel for each region we considered. And we considered 68 regions of cortical thickness. And each kernel had, how can I say, for each kernel we computed a weight, and the weight had the information on the covariate. So the weights were subject dependent and covariate dependent. So doing this, we avoided the preprocessing of the data. So we did not alter the data before using them for the machine learning process. We did not model the effect of age and the machine on the data, because usually what you do is to model typically a linear relationship between the data and the covariates. In this case, we skipped any model which took into account a priori how the covariates could disrupt the data. And we included the covariate in the learning phase. So doing this, we obtained that the accuracy of the classification went to around 75% to around 85%. So we had a huge boost in accuracy. And we found that, again, the brain areas which were related to psychosis were the frontal and temporal regions. So without applying any a priori hypothesis, we found that psychosis was involved with the frontal and temporal regions. So our finding was that accounting for the confounding covariates in the model instead of trying to remove the effect of covariates with pre-processing steps enhances the biological validity of the findings with machine learning. And these results supports some future developments of multivariate and covariate-adjusted imaging-basic diagnostic tools, especially for early interventions in the case of the first episode psychosis. Another more recent work dealt also in this case with first episode psychosis. This is a large multicentric MRI study. So this is interesting because, as you maybe know, in the last years, the community is going towards the collaborative studies, which makes it also more important to deal with heterogeneous data sets. So in this case, we had hundreds of patients and hundreds of healthy controls, and the patients were coming from several institutions, especially they were coming from Santander, Jena, Valladolid, Basel, London, Prague, Rome, Verona, and Munich. And what we tried to do were to exploit this data. We had 428 patients and 448 controls. And the approach here was a little bit different in respect to the other studies, because we did not choose regions, but we used the full brain map. And in particular, we used the brain thickness parcellation. So we used all the vertices without considering the a parcellation in regions. Also, using this approach, which is a bit different, we found that the most involved areas were the superior and the temporal areas, and again, the cingulate areas. So these are areas related to cognition and emotional processing. In this case, the balanced accuracy was not so good. We achieved only 66%. But we found that, again, the temporal regions were predictive of psychosis. And we also found that scanner certification improved the performances and improved the generalizability. This means, again, that the scanner is quite important in this kind of analysis. And what we want to do next is to include also in this study the covariate step in the classification process to see if we can generalize our method to more to this data set, which is in which the numerosity is higher. So in this case, the vertex-wise analysis was better than the regional approach. So what it's still here. So what we want to do next is to combine these two approaches and use the vertex-wise information and the covariate information together with a multiple kernel approach and see what happens, even if it will become a computationally heavy process. Even if the accuracy is moderate, this model shows clinical relevance in the sense that we still can have some information of the neurobiology of the disease, and we find, again, that the temporal region is one of the most important in this kind of illness. In the last technique I wanted to show you is completely different. It is an application of fractal geometry to DTI data. We know that the human brain exhibits some characteristics reminding fractal objects. In particular, fractals are objects which show a structure that repeats itself at different scale, which means that they are self-similar. And also the human brain exhibits self-similar organization, at least up to the resolution we see with the magnetic resonance imaging. So fractal geometry seems to be a suitable geometry also for the brain. So we applied fractal geometry to DTI data. We computed the fractal dimension, which is a dimension that indicates the complexity of the structure we are assessing, with the hypothesis that the fractal dimension may capture subtle nonlinear changes which are not visible with conventional analysis techniques. And moreover, these techniques is suitable to individualized studies, because in the techniques we saw earlier, we can only do group studies, so we can compare the group of healthy controls with the group of patients. With fractal, we can go and see what happens for an individual patient. So it's a technique that could be used for individual psychiatry. So this is a study we published recently, and this is a study in which we apply fractal geometry to DTI of bipolar disordered patients. We had 147 patients and 225 controls. We used a standard technique of analysis, which is TBSS, to do voxel-wise FA comparison between groups. And then we computed the fractal dimension from the FA maps. And in this case, we did group level and individual level analysis. These are the results of the TBSS analysis. We can see that in yellow, we see the voxels where the FA is different in patients in respect to healthy controls. This analysis basically creates a skeleton of white matter tracts, so the analysis is constrained to the center of the major white matter tracts, and then voxel-wise analysis is done between groups. And we can see that the patients show decreased FA, so they show a decreased integrity of white matter, especially in the corpus callosum and longitudinal fasciculus, indicating that bipolar disorder shows a disruption in the interhemispheric connectivity between So the connectivity between hemispheres is disrupted in bipolar disorder. When we did a group comparison of fractal dimension, we found out that there are no statistical differences between groups, but what is interesting is that if we consider singular patients, we can find some tendency at least. So here, we computed the fractal dimension slice by slice, which means that we have for each, we created a sort of atlas, and here we see in blue, the blue line represents the average values for healthy controls, and then we have a shaded area of 3 times the standard deviation, and in red we have the values for a patient, for a representative patient. These are divided for lobe. So we consider the temporal, frontal, occipital, and visual lobe. And we can see, for example, that we have some values for the patients we are completely different from healthy. So that means that in these particular areas, patients show, this particular patient, because this is an individual patient, this patient shows decreased complexity of white matter. And this could be a potential target for medication, or it could be interesting to investigate further what is happening in this specific area. So, summarizing, what we found is that the FA reduces in BD, we already know this, and then we found some localized fractal dimension deviations in individuals. So we highlight the fact that with FD we can detect microstructural alteration which are not found with standard metrics. And our hypothesis is that fractal dimension may offer an individual level lens on white matter changes in bipolar disorder. So concluding, we saw that MRI is a powerful non-invasive tool for the investigation of the neurobiological basis of mental health diseases. MRI studies consistently show structural and functional alteration across all major psychiatric disorders. And then white matter disconnection and cortical thickness are robust biomarkers, especially in schizophrenia and bipolar disorder. So thank you all, and if you have some questions, maybe later, right?
Thank you very much. And now we can proceed with the last presentation of this first session. So, Eleonora Maggioni, who is an assistant professor at Politecnico di Milano, working in the Biosignal Bioimaging and Bioinformatics Laboratory. And the title of the contribution is Multimodal and Multicentric Data Integration for Studying Psychiatric Disorders.
Thank you so much for the introduction, and thank you for the invitation. Today I will show you the potential of multimodal and multi-site data integration and show you some examples of application in the study of bipolar and major depressive disorder. So we know that advances in signaling and imaging techniques have provided unprecedented knowledge of the brain structure and function. Each technique, we know that gives an information that is partial and with a specific spatial and temporal resolution. And this is why only the integration of multiple brain recording modalities can really give us a more complete information on the brain mechanisms. And in recent years, there has been this increased availability of data from a number of participants that has grown immensely, and also longitudinal data from populations and data that is becoming digitalized. So we have the potential to really exploit this data to advance personalized medicine using big data sets. And multiple cohorts and biobanks have been created to this end. but it's still difficult to find a good compromise between the number of subjects and the level of phenotypic detail that can be reached. At increasing number of subjects, we have that the detail usually of the information that is gained is lower, whereas in small cohorts, we still have the possibility to go really in deep in the investigation of the brain mechanisms and the clinical correlates of these mechanisms. And today I will speak you of these two factors. First, I will just give you some overviews of multimodal data integration to increase the phenotypic depth in the study of the brain. And then I will go to an example of multi-site integration where we try to reach big data and big numbers of subjects to increase the statistical power of our inference. So starting from the phenotypic detail, I would like to show you, as Letizia already showed, the MRI, which is the intrinsically multimodal technique that can inform us on brain morphology, on brain structural connectivity, and brain function. And I will focus on functional brain images. With fMRI, usually the contrast that is mainly used is the blood oxygenation level dependent contrast that we know is sensitive to oxygenation changes within the brain. We know that oxygenation changes are, of course, linked to hemodynamic and metabolic phenomena. So we have an information that is hemodynamic mainly, with an excellent spatial resolution, since we have information at the level of each millimeter within the brain and extended to the entire brain. But unfortunately, this info comes with lower spatial temporal resolution, that is in the order of seconds, and also it is intrinsically low resoluted because we have an indirect information of the neuronal activity that is potentially causing the hemodynamic changes that are observed in fMRI. And the direct information on neuronal activity can be obtained using the EEG. The EEG, as Stefania already spoke about, provides information on the synchronization of large populations of neurons with excellent and real-time let's say, following in real time the neuronal activity, and but with a low spatial resolution and giving recordings that are at the level of the scalp. So we have the difficulty in understanding the deep neuronal sources that have generated this signal. This is why simultaneous EEG and fMRI is particularly powerful, because it can solve the issues that are of the single techniques. The EEG has the spatial inverse problem, for which it is impossible to make a certain inference on the neuronal sources that have generated the EEG potentials. And whereas the fMRI has the temporal inverse problem, for which it is impossible to certainly localize in time the neuronal events that have generated the bold responses. And this is why the simultaneous recording of the two signals can give a non-invasive information on brain neuronal and hemodynamic and metabolic activity with high spatial and temporal resolutions. I will give you an example of simultaneous EEG fMRI integration in the case of the study of major depressive disorder. This has been the subject of the PhD of Elena Bondi, who is a PhD student in Politecnico, working in collaboration with the Polyclinic of Milan and the Unit of Psychiatry, coordinated by Professor Brambilla. And Elena worked on EEG fMRI in the study of inhibitory control in major depressive disorder. And we used in this application, which is an exemplar application of EEG integrated with fMRI, EEG was used to drive the analysis of the fMRI activity. We had information on the event-related potentials that were extracted after this go-no-go task. So we had stimuli that could be target and non-target. Related to each stimulus, there was the extraction of the event-related potential, and the fiducial peaks of the ERP, that were the P100 and 200 and P300, were extracted and used in separate GLM analysis to understand the bold responses linked to each of these neuronal events of interest. And doing this, we could somehow extract the brain regions, even the deep ones, that were involved in the event-related potentials that were obtained using the EEG. And these brain regions were then compared between healthy controls and measured depressive disorders in individuals. The results have been just published on Neuroimage and suggest that there is an alterations in the brain regions involved in inhibitory control, and especially in the N200 peak of the ERP and the P300 peak. And these brain regions that showed alterations in MDD versus healthy controls were mainly in the left temporal cortex. And this is the reference to the publication that was out this week. And another example of integration of fMRI is the one with the EKG. In this case, this integration can give information on heart-brain coupling, and this is particularly useful in the study of depression, because in depression we have increased cardiovascular risk, and in people with heart-related diseases, many times we have increased the risk for and susceptibility to depression. And this comorbidity is somehow explained by a number of factors. There are many factors, of course, it's very complex, but one of these factors is a biological factor linked with the autonomic nervous system. It could be that the autonomic brain dysfunctions are somehow related, and this, like the coupling between autonomic nervous system activity and brain activity, can be unveiled using EKG and fMRI simultaneously. And this has been the subject of the PhD of Federica Goffi, a PhD student in Politecnico, collaborating with Policlinico. We have studied still the measured depressive disorder using this combined technique. We processed the two data in parallel, so the fMRI data was pre-processed in a standard way, and the EKG data was pre-processed in order to extract heart rate variability and the dynamics in the sympathetic and parasympathetic activity. The autonomic nervous system dynamics were used exactly as we did with the EEG in a model to drive the analysis of the fMRI, to understand what brain regions could respond to the autonomic changes that were extracted using EKG. And then these brain regions that were somehow linked with autonomic activity were compared between depressed individuals and healthy controls. And the results show that depressed individuals had alterations in the brain responses to both sympathetic and vagal activity. And these brain responses, altered brain responses, were in regions that we mainly were in hippocampus and parahippocampal gyrus and in the precuneus. And all these regions, we know from the literature, are part of the central autonomic network. That is the network that in the brain is thought to control in part the autonomic activity and being affected by the autonomic activity. But also these regions have a key role in depression. So we have a suggestion that there could be somehow an overlap between the brain regions involved in mental symptoms and the ones involved in autonomic dysregulation. A last example of integration I would like to make is the one with between brain recording techniques and neuromodulation techniques. Neural modulation techniques can be used. Some are invasive, others are non-invasive, like the transcranial magnetic stimulation is a non-invasive neuromodulation technique, and they can be used to drive the study of brain excitability and connectivity. And we used it many times, the TMS also needs information from the MRI to be like more precise. So we use anatomical information on the brain obtained using MRI to drive the stimulation in the specific regions of interest, and in between we can also record some brain functional signals to understand what is the impact of the neural stimulation in real time on the cortical patterns and also subcortical patterns. I will just give you a brief example of an integration of TMS and EEG that we have performed in the context of the Subbrain project that was conducted in collaboration between Politecnico, Policlinico, and the University Catholic and the University of Milan. And in this project, we studied a specific emotion that is called the sublime or awe emotion that was induced in virtual reality. We had this motivation to study the awe emotion, that this emotion could be therapeutic for depression. So we wanted to understand what were the immediate impact of emotional experiences in VR in terms of brain activity in the brain regions involved in depression, and in particular in the dorsolateral prefrontal cortex. We then stimulated using the TMS, the dorsolateral prefrontal cortex, and simultaneously recorded the EEG in order to understand the impact of the prefrontal modulation after each VR experience. And the results were obtained by Elena Bondi, who worked also on this project, and we could somehow see how much like the cortical excitability in correspondence of the dorsolateral prefrontal cortex changed after the VR experiences that were eliciting the sublime or awe emotion. And this means that somehow there was an impact that was a real-time impact of this emotion on the cortical excitability. I will now move to the last example, that is on the other factor, let's say the one of multi-site data integration. And in these years, we have worked a bit on like the collection of MRI images on bipolar disorder patients and other patients with psychiatric diseases across Europe and outside Europe. With Professor Brambilla, he coordinated this network that is called the StratiVip network, where we have collected clinical and structural MRI images from bipolar disorder patients to somehow improve the stratification of this complex disorder using brain images. And in the context of the StratiVip network, Ines Sampaio, who is a PhD in Politecnico of Milan in the bioengineering faculty, we created like a normative model using the Human Connectome project dataset. This is a huge dataset that enabled us to create a normative model using brain morphological features. And this normative model was then applied to data from the StratiVip network, including both healthy controls and major depressive disorder and bipolar disorder individuals. And using this normative model and projecting new data on this model, we could extract the reconstruction error of the normative model that is somehow a measure of the brain deviation compared to the normative population. And we could then compare the bipolar disorder deviations with the ones of the healthy controls from the StratiVip network. The normative model was developed using a deep learning autoencoder that learns how to reconstruct as accurate as possible the input data. The normative model was created on the HCP, so the model learned how to construct a normal brain. Then we gave as input the test set that was an independent one from the StratiVip network of healthy controls and patients, and we could then compare the reconstruction error between healthy and patients in the test set. This is the pipeline, which is quite complex, but I wanted to show just that there was a very huge effort in the confounder correction and in the multi-site data harmonization. As Letizia showed, there are many problems in the integration of data from multiple centers, and then we, after having performed the harmonization, we gave data as input in a normative model, and then we did statistical analysis on the reconstruction error pathways. Doing this, we were able also to extract some individual brain deviations. So we could extract maps that told us the significant deviating patterns in each subject. And this is an example of one LT control compared to one bipolar disorder participant. And we also could somehow extract the subjects that were extremely deviating compared to the normative population. And we could then make a sort of prevalence of extremely deviating subjects in each brain region in the two groups. And we found out that bipolar disorder group had an increased number of extremely deviating subjects in some regions, and the one that was most abnormally deviating was the globus pallidus, which is a subcortical region we know is affected in bipolar disorder. And this work has been recently published in Artificial Intelligence in Medicine. So just to conclude, we provided an overview of technologies that unimodal and multimodal technologies and analysis tools. We gave some examples of pipelines also for the integration of information coming from different sources and multi-site data integration. And these, let's say that our results somehow support the importance of adopting a multi-method, multimodal, and multi-scale approach, and of integrating data from multiple sites, and also suggests the power of normative modeling for making personalized inference in medicine. And of course, very important is also the standardization of the techniques that enhances reproducibility in research. And thank you. I would like to thank you, the Bicocca Lab from Polytechnic of Milan and the BrainMe Lab from Polyclinic of Milan. And thank you so much for the attention.
Thank you very much. Now we have 10 minutes for questions, so I invite all the speakers here, and then I ask you if you have any question. Is there any question for the presenters? I have a few questions. I don't know if I catch everything because there was a lot of things and very, very interesting things. So maybe I can start if there are no questions from the audience. The first question is to the first speaker, and sorry to put my notes. I didn't understand how many electrodes did you consider in the different studies that you present?
Okay, so in the first study, for the static approach, so for the motor task, we had 55 electrodes, while the one for the programmers, they were more or less 30. Okay, so in this case, we could use more electrodes because we didn't use the modeling approach. While for the pointing task, where we use the modeling approach, we decided to reduce the number of electrodes to 6, so that it was easier to estimate the model, basically. And in the last one, instead, we were again 55. Sorry, yes, 55.
Scusa, puoi avvicinarti ancora un po'?
Okay. So we were 55, and in this case, in fact, we use the phase-based approach, that is a pairwise approach, so we didn't model the data, and this was also the reason why we need, we can extract a community structure and apply graph analysis.
Okay, and because my interest was in the computational course, especially in the dynamic analysis.
Yes.
If you have a lot of electrodes,
Yes.
it's going to be very heavy.
Yes, yes. That's why we, for the case in which we used the model that was instantaneous. So for each sample we have a model. We reduce the number of nodes. While in the other case, even if it was dynamic, it was a sliding windows approach. So at the end, we had for each trial 22, sorry, 22 windows, because it was 1 second windows that was sliding on time with an overlap of half of a second. So it is less problematic, sample by sample.
Okay, another question is related to if you model also the spatial position of the electrodes somehow in...
We did that.
Okay, because I think it's interesting, but also it's dangerous. I'm not an expert, but I started studying this topic, and experts told me that it's important to take into account the distance, the Euclidean distance, the spatial distance, sorry, but sometimes this is not appropriate because the connectivity is not related only to the spatial distances, so you need to introduce more aspects. And I was curious if you can extract maybe from your analysis what kind of aspects can we introduce in modeling the connectivity, taking into account distances, but something else. So I'm not an expert, but I was curious about how we can maybe do that, observing the results of your analysis. I don't know if it's possible.
I really don't know.
Okay.
I think that it could be interesting, but at the moment I don't know how we can do it. I mean, maybe using, it depends also, but in the sensor level we have the coordinate of the, but maybe it's more appropriate at the source level, where maybe we can also consider if we have it, DTI information, as she was talking about that, because in that case we also have the structural connectivity, and we may integrate the information in that case. I don't know. Yes.
the basis of the last presentation, actually. Okay, thank you very much. I don't know if there are any questions. Yes.
Yeah, correct me if I'm wrong, but I have a question from the second speaker. If I'm not mistaken, for the second study, it was like 100 participants for not healthy controls, but 200 participants as healthy controls. Am I right?
The third study, yes.
Yeah, there were two eyes. I want to know what is the justification, or the what is the justification for that? Is it a problem or no?
No, it's not a problem, because it's that study is not a study with the machine learning, and even if the classes are not balanced, it's not a problem, because we used the healthy data for an atlas, basically. And then for a TBSS analysis, that's not a problem. So it's unbalanced, but it's okay in analysis. Let's say like that.
Also, the machine learning classification task is suitable for like unbalanced modeling.
You have to play a bit with the parameters, but yes. But the machine learning studies I presented, the classes were balanced.
Yeah, great. Thank you.
Thank you.
Other questions? A question for the third speaker, for myself. How did you validate your experiments in the projects? Is there a specific procedure for validation, or is it different every time?
I mean, like the EEG fMRI integration.
Yeah.
So we spent... Okay, sorry. Let's say that regarding EEG fMRI, I have not presented that we spent a lot of time like in removing the artifacts from the EEG that is collected within the MR environment. So there was a long process of recovering of the quality of the EEG signal. So I spent almost my entire PhD on the pre-processing phase of the EEG, simultaneous EEG fMRI, and especially on a specific artifact that was difficult to be removed. And somehow I was, after this period spent on the pre-processing, we published like a pipeline for the pre-processing of and the removal of this pulse artifact from the EEG. And at that point, since then, we are confident that the information that is got in the MR environment is similar to the one that is extractable outside. So regarding EEG fMRI, we are pretty much confident of what we find, but of course also the ERP, so the EEG events recorded in MRI and the extraction of the fiducial peaks of the event-related potential is very challenging still. And we are, let's say, acquiring now experience on that specific event-related analysis. But I would say that we have spent much time on the pre-processing, and it's been, let's say, validated, although it's I think it's impossible to really certainly state that. Regarding ECG and fMRI, and HRV and fMRI, that is a more new field, let's say, and we are still trying to gain new data, also to complement the data that we have, to be sure that of what we are extracting, because we know that we are somehow extracting brain regions responding with the correlation and with the relation with autonomic dynamics, but we still don't know the directionality of this relationship, so there will be many more studies on this topic before being really sure of what we are seeing. But the results are somehow supporting the reliability of what we are finding in the literature. There are some results that are in line and that make us a bit confident, but yes, the process is still ongoing, let's say. And the TMS EEG equal, because also there it's a very big issue, let's say, the removal of the artifacts from the EEG.
Okay, thank you. There are not other questions. Maybe.
A quick question, again, regarding the last talk, and especially the last part of your talk, where you, if I have understood, you develop a model of the brain for healthy subjects. Then you evaluate an error with respect to this model. In the specific case of bipolar disorder, is it correct? My question is it possible to maybe analyzing other type of disorders, finding different errors and then compare different disorders?
Yes, exactly. The idea is that this model is powerful because it enables somehow to extract a personalized metric, because having a reference, and the reference could be normative. We call it normative, but it's like large general population reference. Of course, in this case, they were healthy controls based on psychiatric, in terms of psychiatric disorders. But that is the most interesting part, because then after having like the pattern of deviation of single subjects, new single subjects, we can make a lot of clustering analysis to understand the overlaps between different diagnoses. And in psychiatry, this is becoming really important because there is this transdiagnostic view and dimensional view of the disorders based on even different regions. So we can create normative models for single regions and try to understand the specific patterns that could overlap and the others that could not in certain diseases.
Thank you. Thank you very much to all the speakers. I think there will be maybe more questions. We can benefit of the coffee break if someone of you want to contact the speakers. So now we have half an hour, more or less, for the coffee break. I don't know where exactly it is, but Davide will tell us the path. And I kindly ask you to be back on time, because we have a lot of other speakers, and otherwise we will not be able to do what we want to do, okay? Thank you very much. See you.
All right, thanks again for being here. We can go on with the second session of our workshop. My name is Davide Chicco, and I am an assistant professor at the Department of Computer Science of Università di Milano Bicocca. And the second session is about large language models in mental disorders. So first we will have Dario Palpella, then Giulia Rizzi and Alessandra Grossi, then Marco Cremaschi, and then David La Barbera. So the first talk is by Dario Palpella, which is from the School of Medicine of Università di Milano Bicocca. Prego.
Usare il microfono?
Ah, sì, se funziona, sì.
Prova, prova. Ok.
Va per spostare.
I just prefer to stand up. Okay, here's my bit. I will talk briefly about some computational natural language processing metrics that can be useful for language analysis in severe mental disorder. In particular, there's one metric, global optimality divergence, which was published recently, has been published in a paper by Noor et al. In 2023. And I think it's a really elegant and interesting metrics that can actually solve some of the issue when analyzing coherence and formal thought disorder in schizophrenia, specifically. Just a brief introduction, I collaborate mostly with Unibib Psychiatry Milano Lab, led by Professor Carrà. And I believe last time Cristina Crocamo was here to speak about the project that we work on. Starting with an introduction on schizophrenia, it's severe mental disorder, as you may know, and it's one of the leading causes of disability and has a significant impact on everyday life of the patients involved. There are several categories of symptoms, such as positive symptoms, which relate to hallucinations and delusions, negative symptoms like apathy, lack of motivation, lack of will, blunting of emotion, cognitive symptoms more related to problems with attention and memory, and finally, disorganized symptoms, which is, let's say, the core in my presentation. And these are also core features of schizophrenia, and they're more related to conceptual disorganization, difficulties in abstract reasoning, and reduced language coherence. We also call this formal thoughts disorder in schizophrenia. They are also associated with poor functioning and poor quality of life. And an hypothesis is that some of these difficulties may reflect abnormalities in association cognition and deficit in relational knowledge, so the way patients put together different entities and concepts. Indeed, human cognition depends on structured internal representation that encode this relationship. There's an area, the hippocampal entorhinal cortex, which is thought to be crucial into this abstract relational knowledge. It goes beyond just spatial navigation. It's thought to be involved also in navigating a semantic relationship within words. And if schizophrenic patients have issues with formal thought disorder and issues with such relationship, it is possible that these issues may be found in this area. It's really hard to quantify formal thought disorder. In psychiatry, most of the ratings are subjective. And I remember from my first year of residency, one of the hardest part is to quantify the incoherence in the thoughts. There are concepts such as tangentiality, where you need to see if a patient, when talking about a topic, gets close to the point and then just leaves the point. And it's really hard because you're trying to understand what the patient is saying, you're trying to think about how he says it, and then you're also thinking about the abstract concept, how maybe it's superficial, maybe it's just reaching the point but never gets to it. So it is a hard task to do subjectively, and it would be really useful to have quantifiable measures. There's one test, the verbal fluency task, it's a cognitive test that has been done for decades, since the 1960s in research and clinical settings. And it's pretty simple. There are two types, semantic and letter fluency task. And the semantic one, you ask a person to name, for example, in 60 seconds, as many animals as he can. And then you count the valid words, how many animals he pronounced, and then you have your score for the performance. The other one is letter fluency, where you ask to name as many words as possible starting with a letter. Usually in English is F, A, or S. And it's very quick. You can do it in very few time and with no cost. Semantic fluency, in particular, taps into relational semantic memory and the structure of the category, so the representation of the words that are pronounced. Even though you are restricting to a specific category, you still have, let's say, subclusters within that category, for example, animal. And so you can see how the patient or the healthy control navigates through that part. And while verbal fluency tasks have been present since the 60s, we have now recent advancements that can help us in analyzing how people navigate the semantic space. This is not really novel. It's just fast text, which is a word embedding model where you can take any word from a language and replace it with a vectorial representation with high dimension, with 300 dimension specifically. So with this tool, you can represent an entire language within a semantic space. It allows, it's based on distributional semantics, but even though the method has nothing to do with semantic per se, it actually allows for static proxy measurement of semantic proximity. As you can see in the imaging example, this is just a representation on a 2D map, but you can see director and executive gets clustered in one area, and they're more closer together than rabbit, cat, and puppy. And there are more advanced models, but for a list of animal words, I believe, I will have to test, but I believe it's this model that is not contextual and static is sufficient. And this approach has been increasingly used in psychiatry to study language abnormalities and formal thoughts abnormalities. And it could be potentially useful in addressing this difficult task. So in my lab, we have a project that where I aim to apply this topic, let's say, which is called the Speak Up study. Again, it's the rationale of the study is to find, since we have a lack of standardized acoustic and semantic markers for the assessment of severe mental disorders, there's need of more study, as many as possible, to find some of the features that can be reliable, consistently reliable. So it's an observational study. It aims analyzing predictive factors of severity through the use of a mobile app called Speak Up. And the hypothesis is that there is a potential predictive capability in the assessment of psychopathology using semantic or acoustic features. Just briefly, we recruited subjects over the age of 18 from May 2023 and to November 2024 in both hospital and community settings. We have a mix of acute patients and, let's say, stable patients or chronic patients. The diagnoses are all severe mental disorder, either in the schizophrenia spectrum disorder or bipolar disorder. They just have to express willingness, sign an informed consent, and their task basically involves using this app where we have 5 different classical neurocognitive tasks, and they are recorded while they perform them, and then we extract the data from the speech that they produce. So this is just a screen from the app. We have, therefore, multimodal data set. Not only we have clinical ratings of the symptoms, this is a scale for depression, this is for mania, and this is for schizophrenic symptoms, let's say. We also have the performance in the cognitive test, just prose recall and verbal fluency, for example. And we finally have the features extracted from speech. We have prosodic features, phonation duration, number of words, silence, and latency. The acoustic ones, fundamental frequency, jitter, shimmer, and harmonics to noise ratio. And this is what we use, at least for now, in the one study that was published on SpeakUp. What was missing, at least till this point, is an exploration of the linguistic features of the produced speech. So, for example, semantic coherence and lexical richness analysis. This is the study that was published. This one was on bipolar disorder, and we used mostly acoustic and prosodic features. So, going into the linguistic features, some of you may be familiar already with this. In word embeddings, you're basically representing words as a vector. And since these are vector, you can measure the similarity between them, the semantic similarity, by using cosine similarity. And you get basically a value that goes from -1 to 1. It basically tends to tell you how it points towards different parts of the semantic space. And when you subtract 1 minus cosine similarity, you get the cosine distance, which is what I use in my analysis. This is a distance matrix, for example, between the words in a verbal fluency task. And that's just the concept of the two vectors. The first metrics that have been applied in my analysis and also in general in this field is just the mean consecutive distance, semantic consecutive distance between the words. You just look at the path. Let's say it said rooster, turkey, and whale. You just measure the distance between rooster and turkey and whale, and you average them across the entire length of the list of the words that are pronounced. And as we see, even in our analysis, but this is also in the literature, there are spurious results. You compare psychotic patients and controls, and you see that there's basically the same distance between words. If you look at the mean consecutive distance, there's not much of a difference. There are some studies that found differences there, but others that just have the same results as us. And so we cannot say, at least from this metric, that psychotic patients tend to use concepts that are more distant to each other in this task. So there's almost like something paradoxical. But there are issues that have been pointed also in other research. This metric, the mean consecutive distance, may be sensitive to the difference in performance between the two groups. Healthy controls, they produce almost twice as much the words. And when you, in an animal fluency task, when you produce many different words, you're bound to have more jumps in clusters between, let's say, farm animals to jungle animals. And also you're bound to have more switch between the clusters, and therefore have a more wide-ranging vocabulary, more distances. More jumps means higher average distances, which doesn't reflect a tendency to do this jump. It's just the way, let's say, optimal strategy works. This is a psycholinguistic study. It's a classical study that just found that in order to produce a higher performance in this task, the best strategy is to have many jumps, maybe do a brief path in, let's say, farm animal, and before you exhaust your option, you jump to another one, which is something that psychotic patients tend less to do, and maybe they have less distance because of it. So we need something, basically, that can adjust for the differences in not only list length, so how many words were produced, but also the item of the list membership. And here comes that metric that I was talking about at the beginning, the global optimality divergence. The first part of this metric is to find an optimal path an optimal path between the list that was produced and the shortest one that we can get. To do so, I used a modified traveling salesman problem using Google OR tools. It's basically the same problem, but instead of closing the loop, it keeps an open loop by adding a node that simulates, let's say, the end of the solver solution. The start node is fixed at the word list, and the end node is iterated over all candidates until it finds the shortest path. So in the first step for the global optimal divergence, we fix a window length, let's say 7 for our analysis. We compute the divergence in total semantic distance between what we observed, what was pronounced, and what would be the most optimal length, most optimal path, let's say. And then we normalize this discrepancy between the observed and the optimal path by shuffling the item in the window n times, let's say 1,000 times, and then measuring the discrepancy between the random shuffles and the optimal path. So we get a distribution of the average discrepancy with random permutations, and with this distribution we can zeta score what we observed in the candidate, in the test subject. In this way, basically, we are assessing how well non-random is the selection of the order of the ideas that were presented, of the word. And these are a comparison between the two metrics. So the mean consecutive semantic distance, as I said before, has no difference at all. The mean global optimality zeta scores by group, negative, more negative is better, is less random, starts to show a trend. Here the p-value is 0.17, but these were just preliminary analysis, and I'm confident there might be a different picture after more work. But it already shows a difference, an important difference between the standard coherence metrics, which I think is important when you deal with these two groups, so I'd say psychotic with severe disorder, because there's a big difference in performance between the groups. So I will say that global optimal divergence is better suited, I was saying before, for this comparison. It adjusts for differences in performance and vocabulary using a window, and also by referencing each word with itself, because it's a random permutation of the same words. And it's anchored to a baseline semantic efficiency, how well the person was able to order the ideas. I think it's better related to the performance in the task compared to the basic coherence metric. At least it explains a bigger portion of the variance. And I believe it may pinpoint to specific symptomatic domains in psychosis. So verbal fluency task, it's a general cognitive test, it points to different things. But with these metrics applied to desk task, I believe you might have something that follows better the conceptual disorganization, the formal thought disorder that we were talking about before, and even, for example, clanging association, but this is another thing. I don't think I have, how much time I have yet left? Few minutes. Okay, and I'll just go on. This is just a summary of the metrics I was explaining. We have the coherence metrics for window 2, so the mean consecutive distance. We start from the words that are pronounced, we make a distance matrix, and then for the optimality, you do bootstrap random permutations of the word in order to have a zeta score to get the optimality metric. And for the coherence, it's just averaging the distance. And then we have the window size. It's a global because we slide the window across the whole list. In conclusion, I think this metric is quite interesting and useful because it can be applied to legacy data from standard semantic fluency tasks. I believe there are plenty of data sets, even from decades ago, that have animal fluency data, even on psychiatric patients. It's quite efficient computationally. It's just a solver for the traveling salesman and some permutation, and it was quite fast to run. It's possible that it's a state marker sensitive to speech disorganization seen in psychosis and schizophrenia, even when the performance is preserved, and could provide symptom-specific insight, potentially mapping the conceptual disorganization, tangentiality, or clanging more than the total word count, which is the performance of the test. It's also easily generalizable across data set. You just have, as long as you have the same window of lifetime, if you leave, it's possible to replicate. And yeah, that's all. Thanks.
So thank you, Dario Palpella. You can leave it. We move on to the next speaker, and then we will have the question and answer session at the end. So The next speaker is Alessandra Grossi, who is okay, Alessandra Grossi is a research fellow at Università di Milan Bicocca.
Okay. Thank you all. Good morning, everyone. My name is Alessandra Grossi, and today I would like to introduce you the work I made with my colleague Giulia Rizzi, that is MindIt, a multimodal sentiment analysis system for detecting mental health disorder in Italian speech. But who are we? Our group is composed by me and Giulia Rizzi, and we both are research fellow in the Multimedia Signal Processing Laboratory of the University of Milano Bicocca. In particular, Giulia is a postdoc research fellow at the University of Milano Bicocca, and she focused the analysis on the natural language processing and machine learning. By my point of view, during my last year, I analyzed in particular the speech, so in case of recognized emotion. So the idea behind MindIt, the idea behind MindIt is to merge our knowledge in a common field that is recognized speech from recognized mental disorder starting from speech. In fact, speech can be analyzed considering two different components, an acoustic component and a textual component. The acoustic component is how the words are said, while the textual component includes the words pronounced during a speech. For this reason, these works that now I introduce you is the merge of our knowledge. But why we select the mental disorder? Because this field is a very hot topic in the last year, in particular after the COVID pandemic. In fact, after the pandemic, the number of persons suffering this particular disease has increased. Here are some numbers and statistics. For example, the number of person that suffer of major depressive disorder, he is more than 300 million individuals. For what concern anxiety disorder, more than 400 million people worldwide suffer this disorder, while more than 40 million people suffer from bipolar disorder. Although the importance of this topic, the literature about this one is relatively new, and there are still studies that try to recognize disorder starting from speech. In particular, the majority of these literature works focus their analysis on identifying the most relevant acoustic and linguistic features that better correlate with the disorder. An example is shown in this slide, and where in a review works that the one of Hacker and Alter, there is a summary of the main important, for example, acoustic features analyzed in this topic, and is shown the relationship with the mental disorder and the severity of the mental disorder. In particular, in the image, you could see that the color is used to identify the correlation, positive or negative, with the disorder, while the dimension of the square represent the number of studies that consider this specific disorder. Okay, all these works, however, consider above all proprietary data set and consider a limited number of subjects. Just as an example, we can see that for depression, there are very few datasets, and in particular, there are very few available datasets. In fact, for example, by my analysis, I found more than 25 not available datasets, but only 3 available datasets that could be used freely from the research community. For what concerns the number of participants, they generally are collected by less than 100 persons, and they generally consider a single language. So, about this point, the majority of the datasets are in English, in Chinese, and in Turkish. Here we can see that the Italian language lacks, above all for the available dataset. One of the most famous datasets related to this topic is DIQUOTS, that means for Distress Analysis Interview Corpus Wizard of Oz. That is a dataset collected from more than 193 participants that perform interview between a person that can suffer from distress and an animated virtual interview called Heli. During this interview, the Heli asks some question to this person and they try to answer. This dataset, we have both the textual transcript and the raw audio of the different interview. And this dataset is in English. Okay, so this is the problem, and the major problem is related to data scarcity. How can we solve this problem? We have proposed 2 different strategies. The first strategy is to define a multimodal approach that exploits knowledge learned from specific mental disorder and fine-tune this model to a different language. In this case, the idea is to train the classifier using the data, for example, from the DIQUOTS on English, and then fine-tune it to Italian, because the objective, the final aim of our works is to recognize psychosis in Italian person. The second possible strategy is to use a similar but different speech task that is a sentiment analysis. Uses this model trained on sentiment, we want to extract features that can be then used to train a classifier able to recognize a specific disorder. So let's start with the first model. Okay. The first model, as I said before, include the training of a model using data already collected from persons with mental disorders and in English, and then fine-tune it to Italian. So starting from the speech, we use a dataset that has DIQUOTS to train this classifier and then fine-tune it or adapt it to a different language, like in the case of Italian. This work is similar to a work I have already presented and done before in case of speech emotion recognition. In this case, the task was to recognize emotion starting from speech, starting from a dataset of a young adult in Italian, and then adapt the model to the case of different age or the case of a different language. In this case, the different age was elderly people, while the different language was Italian. A different domain adaptation strategy was involved, including a strategy based on instance method domain adaptation, like CLIEP or Transfer Adaboost. And as I said before, the idea is train first of all the model on English and then adapt it to Italian, or train this model on young adults and then adapt it to older adults. Here I report only the performances for the case of languages, that is the most similar to our case. As we can see, the use of domain adaptation strategy to adapt to the language allowed to increase the macro F1 score from 35% to 34%. So the use of domain adaptation in case of acoustic component for adapt to the language can increase the performances. The same is not for the text. In fact, in the text, they generally train a model using a multi-language dataset and then adapt it to a specific language, like Italian, because the model have to learn the semantic behind the language. So it's not possible in case of text starting from English and adapt it to Italian. For this reason, okay, I don't know why the slide is so bad. For this reason, we decided to focus our attention on the second idea, that is the idea behind Mindit. The idea here is to exploit the knowledge from a similar speech task to extract a feature used then to train a specific model able to recognize psychotic subject from a healthy subject. In this case, we consider sentiment analysis as a base, but there is a difference between sentiment recognition and emotion recognition. In sentiment recognition, the idea is, starting from speech, define a model able to recognize a positive, negative, or neutral emotion. So the idea is to recognize the polarization of the emotion. For what concerns instead the emotion recognition, the idea is to define a classifier able to recognize, for example, the 6 categorical emotions that are, for example, happy, sad, anger, fear, the one of Inside Out, if you have said, if you have watched the film. Okay, but what exists in literature about sentiment? In case of text, there are different models based on deep learning and model based on encrypting linguistic features. We have a large number of datasets, both in English and in Italian, and also multi-language dataset. And with respect to our specific task, we have also large corpora with a high volume of labeled data. Here, the problem of this pre-trained model is that this model challenges detectivism, sarcasm, irony, or mixed sentiment. Similarly, for what concerns the emotion recognition in case of audio, we have a larger number of datasets, both in English and in Italian, with a higher number of data labeled. Even in this case, exists a pre-trained model trained using both deep learning based on deep learning method and using encrypted features. Here, the problem are two. The first is that the majority of that the majority of the datasets are labeled using emotion, so we don't have a data set labeled with sentiment, and the other is that the majority of the data set are acted. What does it mean? It means that they are collected from actors that try to play a specific emotion, try to emulate different emotion, different utterances try to emulate different emotions, sorry. Okay, so what is the idea behind MindIt? Starting from the audio signal, the first step is to performing a general audio pre-processing. That means remove noise that could be, for example, environmental noise or noise due to different device of acquisition and so on. Then the idea is to identify the part of the speech that contain voice. In this voice activity detection step, we have to perform two tasks: to remove the silence and to remove the silence and to identify the voice of the different speakers. Because, for example, in die quotes, we could have in a same audio file both the voice of the interview and the interviewer. So during this activity, we have to separate the two parts of the audio. The next activity is, okay, starting from the speech, we have to transcript the text. So using a speech-to-text algorithm, for example, based on network, based on other algorithm, we can convert the speech audio into the relative transcript. Now that we have the audio and the transcript, another step of pre-processing will be performed. In this second pre-processing, that is component specific, we apply a different pre-processing according to the component we have to analyze. For example, for text, in this step, we have to remove stop words, divide in n-gram, and so on. While for audio, the idea is, for example, to divide the audio signal into segment, extract the spectrogram, and so on. This second specific pre-processing depends to the final model we want to train. Okay, so once we have our two pre-processed components, audio and textual, we could use them as input to pre-train the to pre-trained sentiment model. In using this pre-trained model, we could extract the embeddings that are a latent representation of audio and textual. Example of pre-trained model are, for example, in the case of Italian, are, for example, for the text, feel it, Italian sentiment, while in case of audio, there is a fine-tuned version of WAV2VEC that is then fine-tuned on Italian speech emotion recognition. These two embeddings can be then merged and used as input to a final layer, able then to recognize the healthy subject from a subject with specific psychosis. So, what are the novel behind MindIt? MindIt is a novel multimodal approach for the identification of mental health disorder on Italian speech. The idea is that MindIt allows to learn a mental health-oriented latent space representation that incorporates multimodal information and try to overcome the problem of data availability. In conclusion, MindIt represents a significant step in the definition of a model that can allow to assess and continuously monitor patients with psychosis disorder using a not invasive way, like in the case of speech, and creating an accurate, inclusive, and effective models. In future works, our idea is to apply this pipeline to real data and in a real scenario and evaluate the performance of our model. Thank you so much, and if you have any question, we will happy to answer during the question session. Thank you, and sorry for...
Thank you, Alessandra. Very nice talk. Yeah, we will have the last speaker of the session, then we will have the question answer session. So the next speaker is Marco Cremaschi, that is from our department.
Thank you, Davide. Good morning. My name is Marco Cremaschi, and I am a researcher at the University of Milano Bicocca, and I am also a co-founder of Watadata. Okay, and I am a co-founder of Watadata, a university spin-off focused on digital innovation in the field of psychology and psychiatry. I am also the creator of the project DIPS, Digital Intervention in Psychiatric and Psychological Services, that is a project funded by Ministero dell'Impresa e del Made in Italy. With me, there are also Davide Di Tolve, another researcher at Unibib that developed the work that we will present. In the field of the DIPS project, today I wanted to present a work called LLMind, a decision support system for psychology based on retrieval augmented generation on ICD-11. In order to contextualize this work, I would like to introduce a little the project DIPS. These slides present two main focus areas of this project. The first is the predictive model. Here we want to develop an advanced model that increases our understanding of a specific mental health condition, and we want to develop a platform to support clinicians and care team in adjusting their intervention related to a specific disease. This model acts as a decision support tool that makes clinical reasoning more informed and, of course, data-driven. The second area of intervention is it's a timely intervention. This refers to the ability to take a quick and effective action when early signs of relapse or personal safety risk appears. The idea in this case is to empower user and of course also the clinician to seek help through a platform, and in particular for the person try to detect or anticipate clinical situation thanks to some model that evaluate a lot of data in order to detect some risk factors. In the DIPS, we focused on four key clinical groups that represent some of the most prevalent and functionality impairing psychiatric condition. These include the ultra high risk of psychosis or experiences the first episode of psychosis, the patient with personality disorder, patient with mood and anxiety disorder, and people affected by also eating disorder. This has been designed with the flexibility in mind, making it suitable for different contexts. For example, it's possible to use it in the context of hospital or organizational settings. It supports the integration of the data to evaluate overall treatment effectiveness. We can also use the platform also at the therapeutic level. It gives to the therapeutics, real-time access to the patient's data through some custom tools. Finally, we want to use this platform also at the research level. After the anonymization of the data, we can contribute to the national and international study, enabling a large-scale analysis and evidence-based innovation. The technological solution is made up of 4 components that we will describe: a PSI tool, a patient management platform for clinicians, a clinical decision support system in the field of psychiatric and psychology, a Penguin, an app for the patients, and of course, different kind of chats. In the next slide, I will quickly show some of these products. In particular, the first one is MiCare. MiCare is a web-based platform for mental health professionals, for the clinician, designed to manage patient data, to also monitor the treatment progress, and there is also a scheduler for different kinds of activities. It offers tools for administer a clinical questionnaire. For example, we have developed more than 30 psychodiagnostic tools, like SOFA, PQ16, a Rerouse, in relation to all the different diseases that we want to consider. In this platform, you can upload several documents, assign tasks, and generate, of course, personal medical reports in a more or less automatic way. Penguin is a patient platform accessible via mobile app. It provides therapy-related information and enables real-time communication with the therapist. The key features include, for example, access to psychoeducational content. There are some interactive tools, and of course, also in this system, there is a chat to provide a continuous support to the patients. Ariadne is the new one. Is a platform that connects patient and therapist, but online, allowing them to manage appointments, complete digital diaries, assignment, and of course also deliver some psychodiagnostic tools or questionnaire. More or less, it's similar to the Uno Bravo or Serenis, but is more economic with respect to the therapeutics. ePatients is a web-based tool that we are developing with David that use a large language model to simulate virtual patients with mental health disorder. In this case, it's a tool for the student because it allows students to interact with realistic, dynamic case studies. It's a tool ideal for example, for training, to improve the skill communication for the student, for the education, and there is also some functionality about decision support. And the last one is LLMind. It's a decision support system built on a large language model on top of a retrieval augmented generation system. It leverages ICD-11 data to assist the clinician in identifying mental disorder by generate structured diagnostic suggestion from natural language input, in this case from clinical cases. The key features include, for example, explainable reasoning, the citation of ICD-11 source, and the chat-based interface for interactive exploration. Why clinical decision support in psychology? Because we have to say that despite the growing adoption of AI in the healthcare, mental health remains one of the most unexplored and unserved areas, because in this case diagnoses are complex, are often based on subjective symptoms and nuanced clinical judgments. In this case, clinicians must navigate large volume, for example, of unstructured data without an adequate support tool. Our motivation was to explore how large language models, when anchored to a solid framework, in this case the manual, the ICD-11, and a part of the DSM-5, to provide a system that could assist professionals in make more informed, consistent, and timely diagnostic decision. As I said, LLM is developed on top of the ICD-11 and part of the DSM-5. The ICD-11 is the International Reference Classification for Health Condition developed by World Health Organization. It's a structured and standardized system that ensures consistency in a clinical diagnosis worldwide. Our work focuses specifically on Chapter 6, which address mental, behavioral, and neurodevelopmental disorder. This chapter includes all the conditions typically encountered in psychiatric and psychological practice and form the foundation of the dataset used to train our system, to train our model. This diagram shows how we build the dataset that we will be used in the REG system. We start with the ICD-11 API. We extract and cleaned diagnostic code related to the mental health. In the same way, we process the ICD-11 clinical description and diagnostic requirement, is another manual, to extract rich clinical description. These two sources were merged based on a diagnostic code, and in order to produce a structured and well-annotated dataset. The result is a comprehensive CSV file that serves as the knowledge base, as I said, for our model, combining taxonomy and clinical context in a machine-readable format. This diagram shows the main step of the system, which support the diagnostic reasoning inside the LLM. It starts when a user, the clinician, enter a clinical case description that usually is a short paragraph that contains, for example, symptoms, the history, or the behavior. This text is then converted in a numerical vector into some embedding using Neolama. In order to enrich our system with with particular features. This vector is then used to search Chroma. Is a database, is a vector store which has semantic embedding obtained from the ICD-11 and from the ICD-11 CDDR. This means that the system doesn't use the random data from the internet, but only trust clinically approved information. The response will be contextualized. The system finds the most relevant disorder using the context and the cosine similarity, because we have the vector, the representation of the clinical case, and the disease uses some vector. And after that, provide the results to the GEMMA model, which make the final response. This modular design also makes it easy to update, because, for example, if a new version of ICD-11 will be delivered, simply convert these in a CSV format. It's possible to update. In this way, it's possible to update our system with the new version of the manual. Right.
Thank you, Marco. And let's see how our system works. Our system started from the DSM-5 cases. We extracted 104 cases, and we focused on Juanita Delgado. Juanita Delgado is a 35 years old, unemployed Hispanic woman presenting chronic depression, suicidal ideation, and social withdrawal. Also, it suffers from poor hygiene. She has also a history of emotional instability, impulsive job quitting, and self-harm. Let's now break down the input up to the output of our RAG system. We start from the clinical query input, as you can see in yellow, and we asked our system, based on the ICD-11, make a diagnosis. Then we embed the query inside vectors, and we try to search in our vector store the context construction, and then, thanks to the LLM generation, we retrieve an output. The output now is a string based on the ICD-11 context, and as you can see, we provide the code 6D11.5 and some information and discussion about the clinical cases and also the diagnosis. So let's see the output we got. Based on the provided information, Juanita Delgado symptoms suggest a diagnosis of borderline disorder, personality disorder, 6A10. As you can see, we have the diagnosis according to the ICD-11. Also, there is a brief discussion, a history of unstable relationship, intense anger and impulsivity, and so on. So, as you can see, we have two different parts, the code, the diagnosis, and the discussion, as the DSM-5 books suggest us. Then we move to evaluation. We did two different types of evaluation. Automatic one, based on the first symptom, on the first diagnosis provided by the book and also by our system, and one manual done by professional health clinicians, mental health clinicians. As you can see, the accuracy with the automatic system was around 50%. Instead, the manual evaluation was around 76%. It's quite high for this kind of research, and also we evaluated the concordance correlation coefficient. It was 0.7. It's a higher degree of correlation between the clinicians. Let's break down all the manual evaluation we have done. As you can see, the correlation index was calculated based on this answer, and they are quite correlated among each other. Now we also run a benchmark against other different competitors such as Mental Llama, MedLlama 2, and Biomistral. As you can see, the accuracy for this model is quite low, below 10%, with a precision with less than 10% again. As you can see, our work, LLMind, achieved a 0.52% with accuracy and a higher precision of 0.55. We must add a note on no diagnosis counts. As you can see, we achieved a result of 0 no diagnosis, so all the cases were diagnoses. Instead, Mental Llama was around 25% of misdiagnosis, and Biomistral achieved a 40 misdiagnosis, around 40% of the total. Let's see our work from conceptual to a real case. We based our architecture on Docker. As you can see, we started from the ChromaDB with the vector store. Then our API, LLM API, retrieved information from the ChromaDB and passed to the tRPC backend based on Drizzle and tRPC backend. Then we have a front end to give the clinician a web-based chat to interact with, made on Tailwind and TypeScript. All these modern frameworks are inside our work. So at the end, the web portal it looks like this one. So it's a chat where you can interact and provide a support to clinicians.
Regarding the future work, we want the results are promising. I want to underline that there is a huge difference between the automatic and the manual evaluation. We have to consider the manual evaluation because it's too difficult to use automatic evaluation in this field. We plan to integrate additional functionality about the comorbidities and differential diagnosis using additional information structured from ICD-11, and we want to integrate this tool in our ecosystem. Thank you.
Thank you, Marco Cremaschi. Thanks especially also because Marco Cremaschi is contributing with his funds for the expenses of our coffee breaks. So a very special thank to Marco Cremaschi. And now, let's clap our hands. The last speaker of this session, which is David La Barbera.
Okay. Can you hear me? Yeah, okay. So, I'm Davide Barbera, I'm a postdoctoral researcher, and I work with Marco Cremaschi, which did a lot I should be doing on contextualizing my work, because it's basically following the same direction he discussed earlier. And the aim of this talk is to start by contextualizing a bit, and then we're going to move to discussing shortly how the framework I'm thinking works, and we're going to move to discuss the limitation, the current limitation, and where we want to go now, before finishing the talk. First of all, I need to make a disclaimer, because contrary in respect of what I usually do, this is a work in progress. It's something which is not published yet, so you will find, while I speak, many gray areas that need to be investigated further, and the idea is that if we have a discussion later, you can help me addressing these. So you will find during my talk not so many results, but a lot of ideas and an overall intuition on what we're doing and where we want to go. So let's start to provide some context. As Marco said, one of the ideas of DIPS is to develop predictive models, and he proposed an example of that, and my project is another which is complementary. So we're focusing in this case on depressive disorders, and the starting point of this reasoning is that during the therapy for depressive disorder, usually clinicians encourage patients to keep journal, diaries, or reflection logs that are some structured text that it's used as part of the therapy. These texts are rich in emotional behavioral cues, but they are not often used and analyzed by the clinician. So the question is, what if we could automatically extract some clinically relevant signal and present them to the psychologist before meeting the patient the next time? Would it be helpful? And of course, given that we need to analyze text, we are analyzing text as everybody does today, using LLMs. And the aim is to develop something which is a structured assistant that will support clinicians by transforming those free texts, we don't know how yet, into something which is structured and aligned with clinical reasoning. A key word here, which is very important for me, it's transparency, because we want to provide not something which the clinician has to blindly trust, but we want to provide something which is reasonable, and when it's not, we want to provide some rationale, some justification for this. So how we're going to do this? Let's move into the framework. We're expanding a bit, and we now can identify 3 main points we're going to discuss. We're focusing mainly on the first one, which is symptom extraction. We're going to move to the symbolic reasoning we do on the symptoms that we extracted. And finally, we'll just give you an intuition how we aim to support the clinician. So let's start with the extraction of symptoms. What features do we need to extract? Well, we're working on depression, so we decided to rely on PHQ-9, the Patient Health Questionnaire, which is a tool which is used for depression screening. And the interesting thing here is that PHQ-9 maps to 9 interpretable symptoms, or items, I will call them both, which are the one you can see in that nice figure I generated. And the also more interesting thing is that PHQ-9 is nicely aligned with DSM and ECD-11 diagnostic criteria, so we can use it. How does it work? Well, for each of the 9 items, usually we assign a score from 0 to 3 that goes from not at all, I can't feel that thing at all, or 3, I feel that thing every day. And how we measure it to have an indication, we sum those scores to have an indication of the severity of the illness. The point is that we have some gap here, because usually PHQ-9 is compiled by the patient, so you may argue, how can we infer it from the text? We're using 2 methods for now, we're combining 2 methods, and there will be a lot of discussion on this. Of course, the first methodology is a LLM-based approach scoring of PHQ-9. So we instructed an LLM to simulate a psychologist and extract those features from the text. We don't want just the features, we don't want just a score. We asked the LLM to provide a confidence on what he did and to provide a rationale, so a justification, a textual justification. We don't want just the PHQ-9 scores, we also want something beyond scoring. So we extracted some extra features that are helpful in terms of diagnostics, which are temporal information and evidence of impact on daily life. Again, we want confidence and we want rationals. So let's see an example so it becomes more clear. We have some text we want to analyze, and we have our PHQ-9 items. Here I picked a subset for the sake of presentation. So we feed this to the LLM, we ask him to generate with what we said before, and we have a couple of scores. As you can see, we have very high scores, exception made for the concentration item, but if you might agree that if we see only this, it's not informative at all. So the first thing to have additionally is a confidence score, and here things start to become interesting because we see a very high confidence on the high levels and the rather low confidence for the concentration scores. We can add something more, and here's the justification, the rationale. And interestingly, we see that when it assigns a low score, the LLM couldn't find a direct discussion on this, so it said, I couldn't find it, I'm not sure. And usually, this is something derived from the analysis I did, is that when he assigns a high score, he reports a piece of the text he analyzed to support that reasoning. We also extract information for the duration. In this case, he found years, extracting the piece, and found evidence of functional impairment. So the first method was this. We're also working on a complementary method, which is aimed to increase robustness and mitigate model biases, because LLMs tend to overscore stuff, and it's not reasonable. So we developed a second method, which is based on linguistic inquiry and word count categories. And the idea of those categories is that they group words based on their association with different emotional and cognitive processes. The idea here is that we identify the most representative categories per each of the PHQ-9 items using semantic similarity. And if we find evidence of those LEWC categories inside the patient text, probably that PHQ-9 item will be present. So we use this to score as a second methodology, and we combine those signals. So here is the first gray area that I wanted to honestly bring out, because we're testing multiple fusion strategy, and there's a lot of discussion here to be made, because we can't try blindly trust the LLMs, given that they tend to overestimate, and the idea is to develop some satellite approaches that mitigate their overconfidence on what they do, And for now, we have this one. I'm working on a classifier which is trained on the PHQ-9 items. And the final idea will be to have this first step where we have a first main method and a couple of satellites, and to feed all of this to a second step, which is another LLM achieving all of the first step reasoning and performing a final classification. This is not done yet. Still, there are a lot of open questions. We need to evaluate when we trust who. We need to evaluate the agreement. Usually they are in agreement, but not always. So we need to measure when we trust which one. And we need to, one interesting question is, can we dynamically weight the score? So can we adapt it to the patients? We can do it yet because there's not enough data to tailor it over time, but this would be possible with the right amount of data. So we discussed the first step. We now move to the symbolic reasoning. And we use once more ECD-11, which is the standard for diagnostic health information. And as Marco said, also here we're working with the chapter 6, specifically focusing on the depression. The interesting thing about ECD-11 is that provides some symbolic rules that mirror how clinicians reason. So we can look at what they say and map those reasoning into code, which is explainable. And currently, it's limited because we fall back to those three main categories and do not consider extrusion criteria. This is on the to-do list. The interesting part is that we trace the full path through the reasoning. So for each step we take into performing the diagnosis, we preserve all of the information that we detected during the feature instruction with the aim to provide those information to the clinician at the end. So we preserve symptom scores, confidence level, all of the rationales, and we structure this in a structured explanation. We discussed briefly the symbolic reasoning, and now I want to provide you just a quick intuition on what we're doing this, how we present this to the clinician. Now you can see I'm not a web developer from this, but it communicates effectively what it can be done given the information that we extracted. So this is the output from a task, which is not presented here for the sake of presentation, which was confirmed as a recurrent depressive disorder. Why so? Because we met all of the core symptoms. We found 7 symptoms. We found evidence of a duration, which is almost a year, and we have extracted that exact string from the patient text that says this. We also found evidence of the functional impairment, and we have the rational, because the user mentioned some inabilities, and we have a summary of the contributing symptoms. Along with the score, the confidence, and the rationals. So one could imagine some better and presentation done by someone which is more expert than me in user experience that provides this information to the clinician before meeting the patient the next time, and he says, okay, he wrote this. This might help and guide the follow-up meeting with that particular patient. We discussed the framework. It's now time to discuss some limitation and where we want to go with this. Of course, it's not validated yet. We're in the process now to validate this with the expert. And this is an iterative process. We're here on the beginning of the validation process, and in the end, we aim this to be inserted inside the DIPS platform. And the idea is to tailor it in respect of the specific patient. So we could keep track of an evolution during time, but this is not possible yet because there's not the data available. We also need, as I said, to perform an extensive study on the synergies, on the cooperation between how do we extract the features, because that's the key part. If we extract good features, we can present good information to the clinicians. I tested with 3 datasets so far, and there need to test with more diverse data. Especially interesting will be once we have available the temporal information. And of course, we are working into bringing better symbolic reasoning, including exclusion criterion, and also considering comorbidities. Once this is done, we aim to publish this work. So thanks for listening, and hope you have a lot of questions and criticisms, so we can improve based on what you say. Thanks.
Thank you, David. So now we have the question and answer session. So please stay here. I invite Dario Palpella, Alessandra Grossi, Marco Cremaschi to sit here. Sì, sì, no, tu stai pure lì. Okay. Dopo che ho destra. C'è un'altra sedia qua, Scalate di... Okay, do we have any question from the audience, please?
Thank you. From the last study, the last speaker, I mean, I wonder, because some patients may be more descriptive in terms of their narratives and some they may not. I want to know, how did you handle that?
So far we're not handling, but once we have enough data, we aim to do this. That's a question actually I never thought about this, because I wanted the system to work generally and then specifically personalize it. I mean, in the end, I believe that when you have some text which is more than one text, enough text from a patient, you can analyze it and tailor to the specific case. So far, all of the data sets I found have one single text from a single patient, and either you use it to predict something or you use it to tailor something. Yeah, I believe that with the same text it would be an overkill. It would be also conceptually not correct to do the both. So I believe that we need more information on a single patient to precisely do this. So far we don't have it.
This is a proof of my bad relationship with technology. So, regarding the last two talk, I have a lot of questions and inputs actually, but just to give you few. And I speak as a psychotherapist and teacher of future psychotherapists. So, regarding the systems supporting the diagnosis with the ICD-11, I think that maybe a weak point is the entry, the case description. Because being a supervisor of future psychotherapists, the hardest thing is to teach our students to report the really relevant information that allows to an expert to make a diagnosis. So the first input from my side will be to structure a little more the case description. That can be done, for instance, we use a format for case description when we have to do a supervision. That helps a lot because it allows the clinician to focus on which are the most relevant information. And this is one point. The second point is a more theoretical and general point, and is all your systems, from what I understood, are based on the words of the text. That can be the case description or can be the text of a session, okay? So it's based on the words that the patient is saying. It's close to what you were saying. From one point, not always the diagnosis is made based on the information the patient provides by itself, but it's based more on a sort of another sense, that is also how the patient makes me feel during the session. So the input is, I think this will be very powerful to find a way
to combine also this. That can be done in different ways that we can reason on that, because can be due with, I don't know, something that gives a cues on the emotion on the session, that with a facial recognition system, we can think about it. But the input is, I think, that you are missing a very crucial part, that is this one. And including this part will, I think, add a lot. Because if I think the way I do diagnosis to my patient, I not do this just based on what they say, because sometimes what they say can be even misleading, but it's how they say it, and how they behave, and how they make me feel, and how they are in their relationship with me. So it's everything regarding this emotional part that is not based on semantic information. I'm done.
Okay, thank you. Regarding the first part about the LLMind, what we show today is the first version that consider the clinical case extracted from the DSM-5 clinical case that are very, very verbose with a lot of information. The second version is a little bit different because doesn't require that the clinician, for example, insert this kind of description about the clinical case. But the clinician starts to describe the patient, and the system starts to create some question in order to disambiguate, for example, between the top key disease. We are working on it. Regarding the second part, it's super, and I totally agree with you, of course, and I need an help.
Of course, we can help each other, I think, in many ways. I'm also very interested in the part you say, the e-patient, something.
E-patients, yes.
Yes, that is something to simulate patients. That will be very useful for those who teach to
yes, because I know that the
therapies.
student can meet the patient after the specialization and so on, and I think it's very, very late. For the reason we wanted to develop this tool, it's a didactic tool, not, but I think...
Yeah, but I think we can work
okay,
on that.
perfect.
Thank you.
Happy.
Hi, I have a question about the fluency measure. And I was wondering about the choice of fast text as a reference vector space. Especially when you go to the phonemic fluency, adding sublexical information, that is what fast text does, might create confounding in the sense that the measure that you develop might work better than previous ones, but not because the measure itself computed on top of the vectors, but because the vectors also include some information that patient and participants could exploit in producing words especially in the phonemic fluency. So you might have a sort of a hybrid semantic form measure.
Hybrid with other features or with other semantic features?
No, I was wondering, since you have a vector that is both composed by the word itself and its sublexical aspects.
Okay.
You are creating words starting with R, and then you have essentially all the sublexical information start with R that are contributing in computing the similarity between the produced words.
So, for example, an earlier model than fasttext that just represents the word.
Simple word-to-vec. Really.
Okay, word-to-vec. Yeah, it's an interesting question. I have to admit, the analysis I made were done the previous weekend on my part, and I applied the same model that was used in the original, that presented the original metrics. So it was simple follow basis. I thought about which model could be better, and actually during some part of the analysis I had to try and see the differences by uniforming all the animals within the same, for example, Leonessa, the female version of Leone, and changing to Leone and see if that switched something. So it's a good point. It's possible that word2vec could be better. I don't need for the animal fluency task. I'm not looking into the subword segments. So I think you're right. I will have to test and switching the model, but probably it's possible that I could do the switch.
It could even be worse. It could even be worse. I was just wondering whether it's worth to have a control condition with a model without selection.
Yeah, it will be part of my future work.
Okay, do we have other questions? Maybe I have a question for Alessandra Grossi. So you mentioned the usage of some proprietary data sets. So I was wondering, how do they work? Do you need to submit an application to use them, or are they just closed access, so you cannot use them? What's the procedure?
Yes, sorry. The majority of the proprietary dataset are not available, and this is the problem, because you can't neither require them. The dataset I report has available are a dataset that you can require, but the data that is proprietary can be required due to ethical problem, because in this topic of analysis there is this ethical problem that is related to the fact that we work with patients, and that voice is a very sensible kind of data, because you are able to identify a subject starting from his voice. So the majority of the available dataset are not, the proprietary dataset are not available for this reason.
Okay, privacy.
Yes, exactly.
Okay, so we have...
If there are no more questions. Now it's related to this part and to the previous one, the e-patients, I don't remember. Maybe we can create a data set for training algorithms starting from your e-patient. Could it be also, it's only text, or could it be also voice? In the future, maybe it's not something that probably is possible right now, but could it be possible is a question.
Okay. I have to say that we tried different models, and each one performed in a different way. For example, because our main objective is to use an open model. But we also try to integrate ChatGPT and Gemini at first. And I have to say that Gemini, the voice part is not so good. ChatGPT instead could be useful, because it changed the mood, the tone, also the number of the sentences in 10 seconds and so on. But we have to work more on this part, because, for example, we try also to use some open model to create voice, but in Italian it doesn't work.
Okay, so let's thank our speakers again. Sorry.
Yeah, just a question for Cremasti and Davide. I forgot the surname. How did you address any problems that might arise? Since from what I understood, these platforms are real-time, so they have a connection somehow. Professional liability issues regarding having, let's say, an alert on a patient that might be suicidal. And
yes. we want to integrate in the future also this functionality, but it's difficult to develop because we have to consider a lot of information in order to provide a good notification that could be very useful, and it's too early. But in the future, we want to insert also this functionality.
And the counter issue of if you are using the same platform as a therapist and you see these alerts, you might be liable if the app is telling you some patient is in danger, kind of.
Yeah.
Do you consider it's still too early?
Yeah, okay. We have to talk about it.
I would be scared, honestly, if they tell me the platform can tell me when and at which moment a patient becomes.
You have to consider that the platform is developed for the clinician setting, not for the private private therapist and so on. Okay. In this context,
settings.
yes,
Okay.
in this setting it's different. Okay,
Yeah.
This is a functionality that some organization ask, but only about the how to say medical setting.
Okay. Thanks.
Okay, so now let's. There is another question, please.
Sorry. About those of you that generating these platforms, I was wondering, apart from the accuracy and the intervention part of it, did you also investigate the feedback of the patients? Like, are they satisfied using it, or the relationship they have with the application, or do you have any insight about that? Yeah, thank you.
Not yet, because actually only the MiCare are available for the organization. For example, Penguin is not available because we know we have the GDPR and also the AI Act. And we are working on Granted della Privacy to develop a methodologies to, how to say, to follow the regulation from GDPR and AI Act in this field. In the future, we will want to create some user testing about also the Penguin and the other tool more related to the patient.
Okay, so I think we can close this session. Thanks again to the speakers. Now it's time for the lunch break, so you're going to be on your own, and we will start again here at 14:30 o'clock, so 2:30 p.m. And yeah, enjoy your lunch. That's it.